Hey, welcome back, wonderful students. Now we're going to take a look at anxiolytics and hypnotic agents. So when we're anxious or we have this feeling of tension, nervousness, apprehension, or fear about something unpleasant, some unpleasant reactions to some sort of stimulus, or we have sedation, right, which is our own loss of awareness and our own loss of our reaction or a reduced reaction to environmental stimuli. Hypnosis is when we have this extreme sedation resulting in further central nervous system depression and sleep. And then minor tranquilizers will produce a state of tranquility in patients who appear to be anxious or who are anxious. So again, we have psychological states affected by the anxiolytic and hypnotic drugs. Our benzodiazepines would be one that would reduce anxiety or considered anti-anxiety, right? We have sedation meds or hypnosis meds that are like Ambien, Zolpidem, those kind of meds that will help you enter into this loss of awareness to environmental stimuli or CNS depression and sleep, right? So here is a drug therapy across the lifespan in reference to anxiolytic and hypnotic agents. It's important to take a look at it. Talks about both benzodiazepines and barbiturates, right? And the cautionary tales and information is on these forms themselves. Then it also talks about the different antihistamines like diphenhydramine or promethazine that's utilized for anxiety. They're crossover meds. They've figured out diphenhydramine or Benadryl is really good for some patients in reducing some anxiety as well, right? So they have used these as the entry-level meds before advancing to further addicting meds and further meds that have other types of side effects as well, right? Then it goes into what drugs we use for treating insomnia and the fact that they should be cautioned and only used for short-term use. So you will see some patients who are on Ambien for years, but that's not what it's intended for, right? It's more of a short-term fix until we can figure out what's going on with the patient and help get that all regulated, whether it's hormone imbalance or whether there's other factors going on, right? To help them learn maybe healthy sleep habits and things like that. Then the older adult, obviously, with the changes that occur with the elderly, we need to be aware of the fact that they have, their kidneys and liver have deteriorated over time, right? We know that the kidney's ability for the glomerular filtration rate has decreased in the elderly, and therefore they're not able to clear the meds as quickly or as proficiently as they were when they were younger, right? We know that also that medications, because of a number of factors, medications affect the elderly differently, right? And we know that they are going to be on multiple meds. They're going to have polypharmacy going on, possibly, right? And these meds will interfere and will either synergistically affect these meds or counteract these meds. So we gotta make sure that they're compatible, they don't interfere with other meds, and then of course we want to figure out ways that we can help reduce anxiety, help improve sleep by doing non-drug or non-med measures, right? And we did talk about several of those things in class. That include, checking to see, do they have physical problems that's causing pain? And if we'd managed pain, if the patient's pain was managed, would that not interfere with sleep? It probably wouldn't, right? Or are they having neurological deterioration or depression, or that could be contributing to insomnia? Anxiety contributes to insomnia, right? And exacerbates it. So there are all these variables that we need to look into to figure out exactly what's going on with our patient and how, more importantly, we can fix it, right? Okay, benzodiazepines act in the limbic system and in the RAS system. It makes GABA more effective, right? So you get this when after taking a benzodiazepine, patients will get this rush of GABA into their system, and it's that euphoric feeling that they get, right? So we use benzodiazepine in low doses for some patients to help them cope and deal with anxiety, right? And we use benzodiazepines in higher doses to actually perform procedures sometimes, right? For sedation, basically, as well as hypnosis. So we might use them for procedures. We might be doing all kinds of like alcohol withdrawal. So indications, when are we going to use it? Obviously anxiety, right? Alcohol withdrawal, we use benzos a lot for alcohol withdrawal. I have said this in classes, as Marcel has. Withdrawing from alcohol is much more, or can be much more dangerous than somebody withdrawing from heroin, right? As far as the body shutting down, as far as the patient going into tremens, withdrawing from alcohol, it's a serious condition that you're going to learn a lot more about in block 2. So we got to taper the alcoholic off slowly with using benzodiazepines and other meds to help support the patient as we withdraw alcohol from their system, right? It's not something that an alcoholic can do abruptly ever. Stop drinking, right? It's not safe. We have patients who get agitated. They may be anxious to get an MRI done, for example, so we might give them a benzodiazepine for the procedure itself because they're hyperexcitable, right? And then again, when we place patients under for surgeries, we give them general anesthesia. But in addition to that, sometimes we'll give them a benzo on top of the general anesthesia so that it can kind of take the edge off for the patient, right? Because many patients are terrified that, about surgery. So it just helps them relax a little. So what do we know about benzos? They are well absorbed from the GI tract. They peak in approximately 30 minutes to 2 hours, depending upon which one you're taking by mouth. They are lipid soluble, and therefore they distribute well throughout the body. They do cross the placenta, so that is something we have to consider, right, if women are pregnant, right? And they do enter breast milk, another thing that needs to be, a conversation needs to be had with patients who are pregnant and then having babies, right? They're metabolized in the liver and excreted in the urine like most meds, right? PO meds. Obviously contraindicated if you have an allergy to any type of the medication itself. If your patient's in a full-blown psychosis, we would not give them a benzo. If they have narrow angle glaucoma, it is contraindicated because it exacerbates and makes that condition worse. Patients in shock or comas, we would not recommend this. So an acute alcohol intoxication, like literally in the acute event of the alcoholic intoxication, it would not be a med we would lean on. And of course, because it crosses the placenta, we're not going to give it to pregnant people, right? Adverse effects. So adverse and side effects, right? Remember we talked about the difference between adverse and side effects, right? Side effects is kind of things we expect to happen. Adverse effects are things that can go wrong, and sometimes big time wrong, right? So benzos do cause the majority of people to have sedation related to the benzos, drowsiness, lethargy, those kinds of things. In addition to that, it can cause depression, blurry vision, can cause confusion in some patients. Dry mouth and constipation are both common. Some patients, not many, but some get nausea and or vomiting. It does cause hypotension, and they can cause urinary retention, right? We always want to be aware of drug-to-drug interactions. So we know that it increases the CNS depression, when we take it with alcohol. So we always, always advise our patients to ensure they do not take any benzos with alcohol. If they're on benzodiazepines, they cannot drink, okay? It does increase the effect when we take it with cimetidine, oral contraceptives, and disulfiram. So again, don't take it within 2 hours of these three medications, because again, they will increase its effect. Its decrease effect if it's given with both ranitidine and theophylline. So those two meds, again, 2 hours before or after, you want to take the benzos by themselves. Because again, it's going to decrease its effectiveness, and then literally what's the point of taking that med, right? So, okay, so here's the side of action for benzos and anxiolytics on the brain. And then it talks through the different, how it affects the brain. Have a bigger picture of this. Don't memorize this at all, but have an understanding of why benzodiazepines are highly addictive. One, because they have that response in the brain where it gets that flush of wonderful GABA effects, right? That's why it's highly addictive. People love that feeling, right? It feels great when you're severely anxious and then it's relieved and you have a euphoric feeling, right? Okay, here's a practice question. Client presents at the clinic with symptoms of hyperexcitability and agitation. Which medication would the nurse expect the physician to prescribe? Hypnotic, benzodiazepine, barbiturate, or another anxiolytic or hypnotic drug. So hyperexcitability and agitation are both symptoms that benzodiazepines would work really well for. Yay! So we got that right, benzodiazepine, okay? Okay, next we're going to look at is barbiturates. Again, it's a CNS depressant. It inhibits the neuronal impulse conducted in the RAS system. It also depresses the cerebral cortex as well as the motor output, and it does cause sedation, hypnosis, anesthesia, and or coma in some patients. So they got to be very careful with barbiturates, right? So it is another medication that may be prescribed for anxiety, sedation, patients who have insomnia, especially difficult to treat insomnia. It's also used with anesthesia meds before the anesthesia meds are given in the OR. And it is given for patients who have seizures. We know that it's well absorbed. It reaches its peak in 20 to 60 minutes. It's metabolized in the liver and excreted in the urine, like most meds. Contraindicated, obviously, if you have an allergy to it. If you have a previous, history of addiction to sedatives or hypnotic type drugs, we would not prescribe that person a barbiturate. And also, if they have hepatic impairment, so again, if the liver's not functioning at maximum capacity, it's not a med we're going to lean on because it can be hard on the liver. If the patient has any type of respiratory depression, or the opposite, if they're in respiratory distress, severe respiratory dysfunction, it's not going to be a med that we go to initially to treat our patients. And then again, it crosses the placenta, so we're not going to give it to pregnant patients, okay? Again, side effects and adverse effects include it does cause central nervous system depression. Again, it is highly addictive, so physical dependence. It causes drowsiness, lethargy. In a few patients, it can cause nausea and vomiting, but not a lot. It can cause constipation, and in a few patients, it can cause vertigo and ataxia. And then in some patients, it can cause the patient to be really somnolent, which is like that down. They're really down and kind of depressed kind of feeling, right? Drug-to-drug interactions that are important to know. Since it is a CNS depression, that is increased exponentially when taken with alcohol, antihistamines, and other tranquilizers. So it's highly, highly important that patients who are on any type of barbiturate do not drink alcohol, they do not take Benadryl, diphenhydramine, or any type of antihistamine, and they stay away from tranquilizers because that can seriously cause death, right? Respiratory depression to the point where the patient doesn't breathe because it suppresses the CNS so much, right? Also, it's important that if patients are on phenytoin, that they not take barbiturates because barbiturates will alter the phenytoin from working like it's supposed to in the body. Same thing with MAOIs. So MAOIs are certain types of antidepressants that aren't used typically unless the patient has tried all the other types of antidepressants and they haven't worked. So it's MAOIs are a medication you're going to learn about in block 2 when you do psych, and it's for, again, patients whose depression is very difficult to manage. So patients who are on MAOIs, we would not put them on barbiturates typically because it does cause an increase in the amount of that med in the blood, right? And it's important to know that barbiturates reduce the effectiveness of DIG, tricyclic antidepressants, corticosteroids, anticoagulants, and contraceptives. So patients who take barbiturates need to be aware of the fact that it reduces the effect of these things. And if that's the case, then they need to, if they're on anticoagulants, then most likely they're not going to be on a barbiturate. But let's say oral contraceptives, they'll want to use another type of protection, right? So they don't get pregnant. If they're on a barbiturate as well. Question number 2, please answer the following statement as true or false. Peak levels of barbiturates occur in 60 to 90 minutes. We know that's false because we just talked about it. It's 20 to 60 minutes, right? All right. Okay, next medication we're going to talk about is temazepam. Temazepam is a medication that is used for anxiety, for insomnia, for hyperexcitability, for agitation, preoperative relief when you're scared to death to go into the OR for your operation or your procedure. We give them for all of these different reasons, right? Because it does calm the brain. It does cause reduction in anxiety and tension, and therefore, I mean, it works well, right? It peaks in 30 minutes to 2 hours. It is lipid soluble, therefore it distributes well throughout the body. It needs to be used with cautious or not prescribed for patients who are in a psychosis, who have acute narrow angle glaucoma, and who are also in an acute stage of alcohol intoxication. Should be used. Side effects. Well, obviously it has a sedative, lethargic, and drowsy effect, right? It causes hypotension. It can cause dry mouth. It does for many people. It increases the fall risk because of the sedation and drowsiness and all of that. And then just understand that initially patients may get that hangover effect, right? So they're a little drowsy and dragging the next day, right? Many people, though, once they've taken the meds for a couple weeks, that hangover effect will go away. Doesn't go away for everybody, but it does for many, right? Remember that it increases the central nervous system depression when taken with alcohol. So again, we're going to avoid alcohol altogether when on temazepam. Temazepam has a longer half-life in the body, right? So the action lasts around 6 hours. And older adults, we're going to probably start them at 7.5 milligrams as their dose. Okay, other anxiolytic and hypnotic type drugs that are used as crossover meds because they work well is antihistamines. We talked about that, right? Diphenhydramine or promethazine. And many times it will take the edge off, right? The antihistamine will take the edge off with the anxious attitude that might have with pre-op or post-op, right? And they do help when patients take this there is a direct correlation with the decrease in need for narcotics. Buspirone, right, reduces the signs and symptoms of anxiety without causing any CNS, central nervous system depression or any adverse effects, right? Buspirone, there isn't a lot known about how it works in the body, but it does work for some people. About half who take it. The other half say that they don't notice any improvement whatsoever. So, but that's good, right? Half the people can take it and it helps, right? And then we have Precedex, right, which is sedation of intubated and mechanically ventilated patients. I'm not even going to try to pronounce the generic of Precedex, but it's right there. And then we have, for insomnia, we have Lunesta, and then we have Zolpidem or Ambien, right, is another one. And there is, yeah, that's good. We have, don't worry about the top one, Meprobamate. Don't worry about that one. Ramellitin or Rosarim and Tismelatin is a melatonin receptor agonist. So, and then we have Belsomra or Suvrozerant is a oxyrin receptor antagonist. And then, there's the Ambien and Zolpidem. And then we have, don't worry about the other one on the left there, Zalpilon or Sonata. Don't worry about those two. But the Zolpidem and Ambien, definitely know that one. It's a short-term treatment of insomnia. And Ambien is also addictive. And because of the deterioration in the kidneys and liver with the elderly, and how Ambien works in the body, many physicians will not prescribe Ambien to the elderly. Matter of fact, when patients hit the age of 50, they typically will tell them they can no longer be on it just because it's too big of a risk. Okay, Zolpidem or Ambien, again, short-term treatment of insomnia, preferably 3 months or less. You will see patients on them for years at a time, though. It suppresses and calms the GABA neurotransmitters in the brain. It works within minutes of administration. Patients are told that they should take it right before bed. And only if they can devote a full 8 hours of sleep a night. Because what happens if they can't, it's going to cause a major safety issue with the patient. So they could fall asleep while driving, while trying to do their job, all of those things, right? So if they don't have a full 8 hours of sleep, they shouldn't be taking Zolpidem. For some patients, it can cause what's called bizarre behaviors. Eating in their sleep, having sex in their sleep, driving in their sleep, right? All kinds of weird behaviors. So we got to watch patients, have patients and family members watch each other for the first couple nights taking it to make sure they're not going to be the type of patients who are going to have that reaction in the body, right? And that's chemical, right? Everybody's chemical makeup is different, so we really don't know how a med's going to react in someone's body until they take that med. Definitely don't want to give it to patients who have parasomnias. We do not want to give it to emphysema patients. Again, maximum dose for the elderly is 5 milligrams, okay? So Zolpidem usually starts at 10 milligrams. That's the adult dose. It's taken 10 milligrams once nightly. But with the elderly, we're going to give only 2.5 to 5 if they even get it, okay? And then again, they're automatically a increase for fall risks because it has a sedative and hypnotic effect, and therefore it increases your fall risk, right? Percentage. Okay, next is diphenhydramine or Benadryl. Remember, again, it is an antihistamine that has a mild sedation effect and is very therapeutic for many patients, right? Duration of action is around 4 hours. It is also used for allergic reactions. We know that, right? But it's used in this case as a crossover med to one, help with sleep, or two, help with anxiety. It helps with both. Again, the starting dose for a healthy middle-aged person is 25 milligrams. If we're giving it to an elderly patient, we're going to cut that in half to start, and then titrate up as needed. So tolerance can occur with first generation antihistamines, and the biggest risk for patients who are elderly taking it are two things: fall risk and urinary retention, because those are two side effects for everyone, and it gets much worse in the elderly, right? Okay, next medication we're going to talk about is melatonin. So this is a hormone that's naturally produced by the brain that induces sleep in the body. And so what they figured out, scientists figured out, if they artificially created melatonin or created it from plants, natural sources, we could mimic how the body's natural hormone causes, us to go to sleep, right? So it's available synthetically. Again, if the patient has dementia, we do not use melatonin with dementia patients ever, because it exacerbates their dementia symptoms big time. Okay, again, we're not going to use it with patients who are on anticoagulants, because it will thin the blood out even more and it will prolong their bleeding time. Okay, and so, well, it not only will make them bleed more, but it actually changes how those anticoagulants work in the body. So we're not going to use them, period. Okay. Next, we're going to talk about herbal preparations, specifically valerian root. It's in Europe, Asia, and North America. Many people, and evidence-based practice has shown that it doesn't necessarily, there is really no strong evidence that it induces sleep, or really, there isn't really any evidence that supports its use long term. Now, some patients have said it helps them to induce sleep. So on a short term kind of time frame, if somebody wants to try it or they think it might help, we just need to educate patients that it actually can cause insomnia in some patients, and it can not work in others, but that some patients find that it works really well, especially older adults for some reason. Again, we don't know the exact reason why it works well for the elderly, but if they're aware that it could cause the opposite problem, more, make their insomnia worse, and they still want to give it a go, they definitely could try it. It's not going to permanently hurt them, right? But also the other thing, though, to tell the elderly patient, actually all your patients, not just the elderly, is that it does they come in capsules, right? And so capsules are difficult to swallow because they get stuck in the back of your throat, especially elderly, because remember, they have less fluid on board and their mouths are dry and everything, right? So as a result, they need to wet their throat before they take their capsules so it doesn't get stuck. Okay, question number 3 we have: you are admitting a new patient to the clinic. A review of home medication indicates the patient is taking a barbiturate to help them sleep. The patient tells you that he is having problems with both visual and auditory senses. The patient wants to know what is wrong. What would be the best response? A, we will have to wait and see what the doctor says. B, what you are describing could be adverse effects from the sleep medicine you are taking. C, there's nothing wrong. You are just getting older. D, sometimes these things happen with our patients. We need to do a comprehensive assessment before we know for sure. Okay, so knowing that barbiturates can cause adverse effects like visual or auditory senses, I would say it's B. Okay, good. There we go. Nursing diagnoses related to drug therapy might include disturbed thought processes, disturbed sensory perception like visual, auditorial, tactile, kinesthetic, all of that. All right, this is the end of this chapter.